apnea treatment. We are on the giant's shoulders. This presentation was created for the 2022 June GP event held at the Rocks, sponsored by Peninsula Private Hospital and Smith and Nephew. This is directed at the GPs, hence there's some medical terminology, but obviously well suited for patients as well, and approximately 20 minutes long. It'll have an introduction, thereafter some discussions of other treatment options and research data, then our own results, followed by a conclusion. OSA or sleep apnea is a giant, and there's absolutely no doubt about it. Why? Because it's very prevalent. It's as common as 1 in 7 people and clinically significantly affecting about 1 in 10. 45 billion loss. That's how much the Australian government lost in 2017, and only about $500 million were allocated towards management of sleep apnea directly. Some of the losses were direct and other losses were indirect due to other health consequences, social concerns, motor vehicle accidents, loss of taxation, businesses, etc. So what are the health consequences? These are well known. Increased cardiac disease, increased stroke risk, diabetes, hypertension, social dysfunction, as well as a very high risk for motor vehicle accidents due to sleep apnea. So there are a variety of treatment options for this condition, but unfortunately there is not a single perfect solution. So what are the solutions? CPAP. If used, it's a fantastic option, but only about 50% of the patients use it, and other half give up within 2 weeks of its use. Particularly young people find it not particularly compatible with what they wish for. Maxillomandibular advancement, which is surgical correction of the mandible and the face. And it has shown some of the most promising data, showing about 85% success and about a 46% cure rate. But it's facial reconstruction, it's big surgery, quite costly. It doesn't really suit 1 in 10 people to have this unless they have craniofacial abnormalities. So it's once again not an ideal option. Mandibular advancement splint or a mouth guard, it can be very good if there is no side wall collapse or big tonsils, particularly for moderate to low level sleep apnea. But it's not ideal for severe sleep apnea with patients who have side wall collapse, which I will go through in a minute. Weight loss surgery has shown some improvement in sleep apnea and cure some people, but doesn't affect all the people because there are other sites of collapse. So weight loss alone is insufficient to cure sleep apnea, but it does help. Hypoglossal nerve stimulation is stimulating dilatory muscles of the tongue and the airway with the electrical stimulator. It's a surgical implantation of a stimulator onto the nerve, which gets stimulated at night when you sleep. But it's still a device. Not everyone is agreeable to using it. Hence, about 20% of the people who have this done does not take it up. And even with its use, the success rate that's been published, it's in that 40% category, not 70-80% success category, which we like to achieve after an operation. Now, soft tissue surgery with multi-level correction has advanced over the last few years. The older data is poor, hence the overall data is variable. But certainly the modern techniques to lift the soft palate up, open the side walls of the throat and bring the tongue down, or open the lower airway has shown a lot of promise. We want to focus on barbed reposition pharyngoplasty or BRP, which is a technique that we use and also has shown some of the most consistent results from 2015 onwards since its introduction. What it does is use a barbed suture to anchor the side walls and open the side part of the airway and bring the palate upwards. Some of the data has shown improvement between 65 to 93%. Now, 93% improvement does not always mean the surgical technique has been superb, but it may simply say they have been very choosy in whom they operated on. So essentially, if you're more choosy selecting the ideal candidate, you are obviously going to get better results. So essentially what we want to look at is the overall data of this, which has been promising, and we will go through that more in due course. So why a combined specialist sleep clinic? Because no longer we should have this approach of one size fits all in the personalized medicine era. Sleep apnea requires a multidisciplinary approach to look at the airway and the physiology. And rather than trying and retrialing a sleep machine relentlessly, we can discuss other options available if we analyze these patients in a multidisciplinary setup, and it has proven to give better results for these patients. So, what's our approach? I work with my colleague Dr. John Mulder, who's a respiratory physician and a sleep physician, and we have a comprehensive workup for our patients. We go through a clear history looking at other related sleep disorders, as 1 in 3 people can have other sleep disorders such as narcolepsy, insomnia, hypersomnia, etc. And we also look at a pre-clinic sleep study, and in the clinic we do a full airway assessment looking at the anatomy, and then we do a video playback for the patient to understand their own anatomy, and then we have a tailored treatment plan for them. After they undergo treatment, we repeat all of that again after treatment to see how they performed. So the endoscopic examination is putting a fiber optic endoscope in the back of the nose, looking at the sites of collapse. This has been often done in Europe with drug-induced endoscopy in theater, which is quite involved and time-consuming just as a diagnostic procedure. But what we do is get the patient in a reclined chair in a relaxed state, and we go through a grading system to identify the sites of collapse and see how we can assist them. And I'll go through some examples very soon. Once we do the fiber optic airway, we look at the velar pharynx or the back of the nose and see how much it collapses. Then we look at the side walls of the airway, and then the tongue base and the epiglottis. 0 is no collapse, 1 is up to 50% collapse, and 2 is 50 to 90% collapse or 100% collapse. And we grade these parts of the airway, and I'll go through an example. So here's an example of a patient undergoing fiber optic airway assessment. Here we're going through the nose, towards the back of the nose, and soon looking at the velar pharynx. And initially it's open because the patient is breathing through the nose. As soon as the patient starts relaxing and starts breathing through the mouth, you can see it starts to collapse. That's a complete circumferential collapse of the velar pharynx. It's a circumferential collapse. When you go beyond, you can see the side walls of the throat as they gently and surely exhale. You can see the tonsil tissue and the side walls coming together. You can see more prominence of the tonsil on the right side. And you can see that's a partial collapse of the side wall. And the tongue base also has a partial collapse. So this patient would be categorized as velopharyngeal grade 2 circumferential collapse, side walls grade 1 collapse, tongue base grade 1 collapse. So what do we do with the velum and the oropharynx? This is what we do. We're looking at the back of the throat, and these are the tonsils. And hidden behind the muscle is the back of the tonsil. On the side are fibrous raphe called pterygomandibular raphe. The first thing is to take the tonsils out. Then we make some cuts in these muscles, as you can see, and that's the back muscle, and that's the front muscle. You can see the muscle fibers running down. The whole idea is to do a suture technique to pull the back muscle through the cut front muscle into the pterygomandibular raphe. By doing that, you're pulling the muscle into the open area where the tonsil was. So removing the tonsil gives us a space to which we will pull the muscles. So as you can see, it opens the airway sideways and upwards and brings the uvula forwards by its pull. And if you look at the side profile, you can see the tongue base and the soft palate. And by surgery, you're pulling the soft palate up and forwards. And by tongue channeling, bring the tongue down and also open the side walls of the airway, hence opening the overall airway. So that's how we deal with the velopharyngeal and oropharyngeal collapse. And the tongue base, or the back of the tongue, is managed with coblation of the tongue, which is a device to reduce the bulkiness of the tongue. You can think of it like liposuction of the tongue. We generally aim this coblation towards more of the base of the tongue. By doing that, it reduces the collapse and the bulkiness of the tongue. So by doing all of that, we deal with the velopharynx, the side wall collapse, and the tongue base. So the velum by modified Barbary precision pharyngoplasty, lateral wall by that, as well as tonsillectomy, and the coblation of the tongue deals with the back of the tongue collapse. So that's how we address the multi-levels. So the diagram that I drew is not just mere diagrammatic representation, but it's really what happens. You can see in this patient there's hardly an airway when we started, and after resecting the tonsils and pulling the side walls sideways, there's a significant opening, as you can see, approximately 2 centimeter opening. If you try to look at the velopharynx from inside of the nose looking upwards, you can see the tube coming down, the nasotracheal intubation. Initially, we could hardly look in there because there was a complete collapse of the soft palate, and after surgery, it's open. And this is another example where there's partial tonsils present, and the airway was about 2 centimeters when we started. After we finished, it was more than 3 centimeters. Once again, there's better opening of the back of the nose. Here's another patient with significantly large tonsils. In this patient, there was hardly oral airway. Once we took the tonsils out, there was some airway. Then when we put the muscles laterally or sideways, there's a significantly more open area, as you could see. So these are upcoming are some examples of what happened pre and post-operatively. Here's a patient who was not a suitable candidate, ideal candidate for surgery. She had complete anteroposterior collapse of the velopharynx. As you can see, there's hardly any airway. Then we get her to breathe through the nose as we go down. Then you can see the tongue base is very bulky. She has complete collapse of the tongue base and hardly any collapse of the side walls or the lateral walls. So this patient was more suited for a mouth guard because what we wanted is to bring the tongue forward. However, she was quite young, and the dentist was adamant that she was not suitable for a mouth guard due to the risk, and also she could not tolerate a CPAP machine. She was quite young, and she wished to go ahead with surgery. After surgery, this is what happened. The velopharynx has now been completely opened due to the operation. There was still some swelling of the soft palate, but you can see there's a complete opening. She's breathing in and out through the mouth here, trying to collapse that area, but it's not collapsing. If you go further, you will get a view of the tongue base. She still's got a bulky tongue base, but it's not collapsing completely. It's only partial collapse. And the side walls are not collapsing as preoperatively. So preoperatively, this patient had grade 2 anteroposterior collapse of the velopharynx, no lateral collapse, and grade 2 tongue base collapse. After surgery, she has 0 collapse of the velopharynx, still no lateral collapse, and grade 1 collapse of the tongue base. What is the result? She had a 70% reduction in her sleepiness and a 60% reduction of her AHI, or the apnea-hypopnea index, though she was not an ideal surgical candidate. This patient is slightly more ideal because she had more lateral collapse. Now the top part shows grade 2 circumferential collapse. As you can see, it circumferentially tightens up as she breathes through the mouth. When she breathes through the nose, it opens up. That's what you see as you go down. The next thing is she breathes through the mouth again and starts breathing out. You can see side walls are partially collapsing, and the tongue base has what I would say grade 2 collapse. As she deeply exhales, there's 90% collapse of the airway. So in this patient, preoperatively, she had complete circumferential collapse when she was breathing through the mouth, and grade 2 collapse of the tongue base, and grade 1 collapse of the side walls. This is after surgery. Here's the patient trying to breathe through the mouth, trying to make that area collapse, but it's not. It's staying open. So no longer she has any collapse of the velar pharynx. The soft palate is slightly swollen still, only about 3 or 4 weeks after surgery, but there's no collapse. Once we get through, you will identify no longer she has any side walls or lateral collapse. She only has a partial collapse of the tongue base. So she has gone from grade 2 velopharyngeal collapse to none, grade 1 lateral collapse to none, grade 2 tongue base collapse to grade 1 collapse. She is yet to have the post-operative sleep study done, but the symptomatic improvement was significant. She had 23 out of 24 sleepiness. In other words, she could not drive. She was falling asleep on her wheels at the traffic lights, to reducing her symptoms to 5 out of 24. She was able to drive over an hour, come into our clinic with no concerns about driving, and she's allowed to drive now. And here's an ideal surgical candidate. Why? This patient has got predominantly upper collapse. Lower collapse is hard to fix. So she has got complete circumferential collapse, complete tonsillar and lateral wall collapse, and hardly any tongue base collapse. So if you get a patient like this with a significant side wall collapse and an upper airway collapse and minimal collapse at the tongue base, the patient is more than likely going to be cured of their sleep apnea. So this is a good thing about endoscopic examination in the multidisciplinary clinic, that we can tell the patient that, obviously if you don't like a CPAP, you don't have to take it up, because there's a very, very high likelihood that not only we will be successful, but more than likely will cure this patient's sleep apnea. So these are data that was presented at the national conference last year. We have had more patients since, but these are statistically analyzed, hence I'm going to go through these. So at that stage, we had 39 patients within the 12-month period, and 2 patients declined a sleep study because they were feeling too good to come back for another sleep study. And 8 patients were pending. We had 29 patients data set. And since then, we have had more data, and the trend is very similar to what I'm going to discuss here. The mean preoperative sleepiness was 12, which was brought down to 4 after surgery. The mean apnea-hypopnea index was 20, brought down to approximately 5 after surgery. So overall, the results were 70% reduction of the sleepiness, 67% reduction of the apnea-hypopnea index. As a result, 79.3% of the patient had overall success. Success is determined by a 50% reduction of their apnea-hypopnea index and bringing it below a 20. Interestingly, Friedman type 3, which is the hardest anatomy with big tongues and long palates with small tonsils, which are very difficult to surgically correct, in fact had an 83% success rate and a 75% cure rate. Now, one of the reasons that the overall success may be less is some of the patients who felt very much better did not come for some of the sleep studies that we wanted them to do. However, overall, we have found that the patients did very well. Now, if you look at the maxillomandibular advancement, the success rate in the meta-analysis showed 82% with a cure rate of 44, which are really good numbers and been confirmed as some of the best that's been published in literature. In multi-level airway surgery, they looked at 22 studies with 933 patients, and there was 70% success rate with a 17.4 cure rate. So very quickly going back to BRP meta-analysis, in these studies, they showed there were approximately 15 studies from 2015 until last year. This is a brand new operation. This had shown BRP combined with surgery to address the tongue collapse. And most of these studies, they did bigger operations than what we do, like open resection of the tongue, higher advancements, etc. In these studies, they showed variation of improvement between 65% to 93% success rate in this group. So they had very promising data. Once again, 93% success rate was when the patients were selected in a very choosy way, where the ideal surgical candidates with hardly any tongue-based collapse were chosen. Now, in our series, we did not choose patients that way. We offered the surgery for those who were intolerant of other devices or who were clearly not suitable for the devices. So we were not choosy. And we had an overall success rate of nearly 80%. And we had also modified the technique with combining some of the Australian techniques, and the tongue base was addressed with coblation, which is a much more gentler way of reducing the tongue bulk than open resection. So it was done with minimum invasiveness, and there was no significant complications after surgery, and we had some good numbers. The question is this just early stage results? Are these results going to be maintained over the course, or will they reduce? There's a possibility the numbers can change with time, but looking at the data that's been published elsewhere, it's likely that these numbers are there to stay, at least very close to what we found in our in this initial period. So overall, have you got a Don Bradman here, or have you got a Stephen Smith? It probably doesn't really matter. Either way, it looks like from the literature, it's going to stay pretty good. I'll take 63 at any time. And I think even if the numbers drop down a little bit to down to earth values, I believe this new surgical technique has shown promise. And we are proud to say that we are the first to adopt this particular technique in Australia. So at the CSSA clinic, your patients will get a complete sleep assessment and undergo patient evaluation and education, and we'll come up with a tailored treatment program with the input of a sleep physician. And as a result of the understanding, those who do not suit for surgery or mandibular splints have shown better compliance with CPAP because they understand why, and they suddenly are happier to take it up than before. And the combination therapy option is always there when people have significant tongue-based collapse. We can always add a mouth guard after surgery for those who require it. And as a result, we have had good success, and we have researched our data, and as a result, we are able to quote our own data, and as a result, we've shown some progress in the surgical technique. And we are together the only sleep MDT in the peninsula, and we are happy to have been able to do this presentation with our results. So how can you refer your patient to the CSSC, which is one thing that you might like to know? You're already on the website, and it's a simple matter of Googling sleep surgery Mornington to find us. The letters have to be addressed to both Nalaka De Silva and John Mulder because it's a multidisciplinary clinic. And if the patients haven't had a sleep study, we can plan that. And in this particular website, you'll see there is a sleep study request form that the patients may fill, and our staff will see it, and they can call them back to see if they will qualify for a sleep study or not, and either way we can assist them with the sleep study. And once again, I'd like to thank Peninsula Private Hospital and Smith & Nephew for providing the opportunity to present this to the GPs June 2022, and we are very happy to continue our research and the combined sleep clinic in the Peninsula. Thank you.